Okay, so like I was saying, nuclear medicine has a radioactive component and a pharmaceutical component. The pharmaceutical component is kind of like the GPS, and it tells the radioactivity where to go. Technetium is our bread and butter. It's our big radioactive isotope that we use. For instance, if we are doing a bone scan, we attach it to phosphates because our bones are primarily made up of phosphate groups. If we're doing imaging of the gallbladder, which we call a HIDA scan, it is the technetium is attached to what we call Colitech, which is a byproduct of bile. Bile is stored in the gallbladder, so we make this quote unquote fake bile. We make it radioactive. We inject it into an IV in the patient, and it naturally goes to the gallbladder because the body thinks it's bile. And then we watch, for instance, in the HIDA, we watch the gallbladder fill, and then we watch it empty. Nuclear medicine is very much a physiology modality. It's not much of an anatomy. We don't use nuclear medicine to see how things look. We use it to see how things work. Are the body systems working correctly? Is the radioactivity going in the sequence as it should? Nuclear medicine is also very big in cardiac nuclear medicine. It allows us to look at the vessels of the heart and see if the walls of the heart are perfusing, if the vessels of the heart are perfusing the walls of the heart correctly. And it allows us to see if there are any stenosis or any ischemic tissue of the heart. The images here on the left are a nuclear medicine tech injecting the radioactive isotope into an IV. The patient is underneath what they call a scintillation camera or a gamma camera. It has many different names. The names just subsiding to the way they obtain the images. A scintillation camera takes the radiation coming off of the patient, turns it into light, and then gives us an image. The image to the right is what you would see as a bone scan. So again, the patient is injected. There is a wait time associated with the bone scan because we want the bones to accept that radiation and the phosphates associated with it. So the patient would come in, get the injection, wait 3 hours, and then come back for the pictures you see here. The bone scan helps the radiologist to see where bones are being destroyed or rebuilt, where bone tissue is being destroyed or rebuilt. At any rate, if there were any sort of like pathological issues, if the patient had cancer or there was a new diagnosis of cancer. Most patients come for bone scans because they want to see if there's any metastasis to the bone. If there's metastasis of cancer to the bone's being destroyed by cancer cells, hence showing on our bone scan. Radiation therapy or radiotherapy is often abbreviated as RT or RTX. It's a therapy using ionizing radiation, generally as a part of cancer treatment to control or kill malignant cells, normally delivered by a linear accelerator. It is still radiation. The radiation is a much stronger dose than anything coming out of an X-ray machine or off of a nuclear medicine patient. The linear accelerator gives off the radiation in a pencil beam, usually the size of the tip of a pencil. It is very important for the technologist, the radiation therapist, to be accurate in their placement of this beam on the patient. When acceptable, the patient will actually be tattooed for a point of entrance so that every time the patient lays down and they're positioned for the radiation therapy treatment, it's set at the same spot. You would never want to radiate parts of the body that are normal and there are no cancerous tissue, because then you can lead to damage of nodes or damage of healthy tissue. These images the image on the left is actually a linear accelerated. This is how the radiation therapy is administered. And the image on the right is actually a patient placed under a linear accelerator. You can see they're putting in a mobilization device. This is so the patient does not move and the point of entrance does not change. This patient, unfortunately, must have been diagnosed with a head and neck cancer, which does not allow for a tattooing of the skin, and instead they put them in an immobilization device. These devices are made individually for each patient, so that they hit the target tissues every time they come for radiation therapy. Radiation therapy is planned by a dosimetrist and a doctor. The radiation therapist is the one who administers the radiation and puts the patient in placement for the radiation. Magnetic resonance imaging, also known as MRI, does not use ionizing radiation to acquire its images, unlike radiology and CT and nuclear medicine. They actually use Strug magnets. The magnets in MRI are classified into T1, T2, and T3. T standing for Tesla. I'm sure many of you have heard of Nicholas Tesla. He, or the Tesla cars. He is who we credit for our MRI imaging. Without his magnetic expertise, we would not have MRI imaging. MRI imaging is used by a radio signal to disturb the axis of rotation of the nuclei and observes the radio frequency signal generated by the nuclei returning to the baseline states. So what happens is we shoot radio signals into the body. We disrupt the atoms of the body, and then we watch to see how long it takes them to realign to the magnet. That very simple explanation is what gives us our images. We are able to image in multiple planes in MRI. Again, coronal, sagittal, and axial. We can do obliques like we did in CAT scan. MRI is a much better imaging modality for joints, for knees, for shoulders, because it helps us to see the ligaments and if there's fluid in the joints. MRI is a much more specific and detailed imaging for any sort of brain tissue, spine tissue. We image in T1 and T2. T1 makes fluid a different color or a different signal than T2. Depending on which way you're imaging, it will show tumors or vascularity differently. The images here to the left are a magnetic resonance imaging machine or an MRI machine. If you can look, I know it's very small, but her ID badge does not have any metal on it because of the magnetic state of the machine. All patients are screened. All personnel are screened for any sort of metal. It's very important to get a very good medical background and surgical history on the patient. If there's been any implantations, if the patient works with metal or is a welder. Most patients get pre-X-rays, foreign body X-rays done. Make sure there are no metal in the eyes or any surrounding areas, because the magnet of the MRI can actually pull the metal out or heat it up and actually hurt the patient. Also, any patient with a pacemaker is not allowed to have an MRI because it can actually desensitize it and stop the pacemaker from working. There is great danger with MRI with lack of knowledge. If you don't know anything about your patient, or anything about what's been implanted in your patient, the better thing to do is not to have the MRI until they're completely cleared. There has been multiple news stories of patients, and especially pediatric patients, who have gone into MRI machines and a oxygen tank not being MRI safe, or phosphorus, and being attracted to the magnet in the MRI, and the patient being incapacitated, or unfortunately, it being fatal for some of the patients. The image on the right is a picture of the brain. As you can see, the detail of an MRI brain it is incredible. You can see down through the sulcus and the different parts of the brain and the spinal cord. It is a very detailed image in comparison to the other modalities. I hope that this breakdown of all the modalities helps. And please, if you have any questions, send them my way. Thank you.